Good afternoon. I'm Donna McKay, the Executive Director of Physicians for Human Rights, PHR. Since launching last March, this PHR webinar series is on the health and human rights implications of the COVID-19 pandemic. And our goal is to provide a trusted space for healthcare workers, scientists and researchers, advocates, and voices from the front lines to examine and speak to the various impacts of the pandemic on public health systems, on healthcare workers, and at-risk populations in the US and all across the globe. So I want to thank you for joining us today for another timely conversation in the discussion series. We have an incredible panel with us today who will discuss the crippling impacts of structural racism on health outcomes among communities of color, which, as we know, have been disproportionately impacted by COVID-19. Since the very beginnings of the pandemic, Black, Hispanic, and Native communities have been hit the hardest by the disease, reporting higher rates of infection, hospitalization, and death. Well, it is an extraordinary feat of science that we now have 3 vaccines being distributed throughout the US. Communities of color still face inequitable challenges in vaccine access at chronically disproportionate rates. And these long-standing inequities have long disrupted the social determinants of health among communities of color. Today we have the great fortune to listen to experts in health equity and civil rights field to discuss the disproportionate challenges experienced by communities of color throughout every phase of the pandemic, and importantly, the critical solutions needed to mitigate the structural inequities within public health systems for this pandemic and going forward. I'm really thrilled and very honored to welcome today's moderator, Dr. Olugbenga Ogedegbe, who is the director of the Institute for Excellence in Health Equity at NYU Langone Health, and Dr. Adolph and Margaret Berger Professor of Medicine, and the director of the Division of Health and Behavior in the Department of Population Health at NYU Grossman School of Medicine. Benge serves as the principal investigator on numerous projects funded by the NIH, including a global health initiative focused on strengthening research capacity and reducing the burden of non-communicable disease in sub-Saharan Africa. And he is a member of the National Academy of Medicine, has served on numerous scientific panels, including the NIH, the CDC, the WHO, lots of acronyms, European Union Research Council. Benge, thank you so much for leading this conversation today, and I turn it over to you to get us started.
Thank you so much, Donna. It's truly a pleasure to be here. But I think what I will do first is to actually start by acknowledging the unfortunate incidents that our Asian American colleagues actually experienced in Atlanta, and the spate of the hate crimes that they've been subjected to for over the years. And also, I'll be remiss if I don't talk about the recent events in Colorado as well, just to show you the state of where we are in our country today. With that said, and with that acknowledgement, I'm going to dive straight in. I think I'll be remiss if I don't introduce our panelists. So I'm going to start with Dr. Giselle Corbie-Smith, who is the founder of the director of the University of North Carolina School of Medicine Center for Health Equity Research. She is a Kenan Distinguished Professor in the Departments of Social Medicine and Medicine, and a Professor of Internal Medicine, as well as the Associate Provost for Rural Initiatives. She's a member of the National Academy of Medicine as well. Giselle and I go way back, and I'm actually very happy to have Giselle on this panel with us today. Welcome, Giselle. The other panelist I have is Dr. Monique Jimenez. She's an assistant professor of medicine at Harvard Medical School, a course director at the Harvard T. Chan School of Public Health, and an associate epidemiologist in the Department of Medicine at Brigham and Women's Hospital. She's PI of the Harvard Liberation Lab and study individual speak. That's what the name of her lab is, basically called Insight. And this lab examines the lived experience of those incarcerated or detained during the COVID-19 pandemic, a population we often don't talk about enough. Monique and I also go way back. So Monique, welcome. Glad to have you with us as well. And then finally, Eric Ward, Executive Director of the Western States Center, a senior fellow with the Southern Poverty Law Center and Race Forward. He's co-chair for the Proteus Fund, nationally recognized expert on the relationship between authoritarian movements, hate violence, and preserving inclusive democracy. Has over 30 years experience in the civil rights career, and he's worked with numerous groups, government, business, various stakeholders, and is a board member of several groups as well. Welcome, Eric. I'm glad to have all of you here today. Let's dive in. So thank you all, the audience, for joining us on this important conversation about the disparate impact of COVID-19 pandemic on communities of color. Let me start by acknowledging that it's really unfortunate that we've lost over 500,000 people to this pandemic within a year. And it's also unfortunate that these rates affect communities of colors the most. And the figures, they're not flattering. As you can imagine, 2.6 times more likely to die of COVID. Those are Pacific Islanders, followed by Latino Americans, about 2.4 times, followed by Indigenous people, Americans, about 2.2 times, and then of course, Black Americans, about twice as much as whites and Asian Americans. So I see this pandemic, frankly, in three phases, if you may. The early phase between January and June, when it hit across mostly the Northeast and the Western states, and we have some lockdown in businesses. The middle phase between June and November, and of course, the vaccine phase, when the FDA approved 2 vaccines for emergency authorization use. And of course, now we have the third one. So for each phase, I will ask each panel member to reflect on the role structural racism played in both the outcomes of COVID, as well as the government's response as well. Our discussion will be in segments of 15 minutes for each phase before we move to the final Q&A for the last segment. So let me start off. So the early phase, what really happened during this period was we didn't know what to do. The pandemic hit the whole world in a rather rapid manner. There was a lack of knowledge, and there was some struggling about how to mount a responsive public health measure. There was widespread report of the impact of the COVID pandemic in the Northeast and the Western states, particularly in communities of color. In trying to explain these disparities, though, the scientific as well as the lay media focused a lot on the higher rates of comorbid conditions like high blood pressure, heart failure, obesity, which were definitely higher in Black and brown populations, but they ignored the other important exposure variables like poor access to care, healthcare deserts, lack of testing sites, the fact that most Black and brown people were employed in high-risk essential jobs and they couldn't really be locked down in their homes. And then, of course, living in multi-generational households, all of which were factors that exposed folks to get COVID. So these all were mostly driven by the structural inequities and the consequences of structural racism. So Eric, let me start with you. Can you shed some light on the disparate effect of the pandemic on minoritized populations during this first phase? What are your thoughts of why communities of color were impacted more disparately than white populations? And what is your sense of the extent of that impact? Because when we talk about structural racism, it's not just about the health, it's also about the other systems as well. Eric, you're muted.
Here, I am unmuting. Thank you so much for that question. It's such a pleasure to be with you all today. You know, we think about the last year, and it was such a tragic period. We look at the deaths, as you said, of over 500,000 Americans dead. We understand now from studies that perhaps up to 40% of those died needlessly. And we also understand the disparate impact that this has had on people of color. Still, it has been such an exhausting year that I can acknowledge for a second why so many of us are eager to declare the pandemic as past. And I think it is important to revisit the early stages. There is one truism. If inequality exists in the beginning of a process, it will only multiply as it moves through a process. And this is what we saw in response to the pandemic known as the coronavirus. From the very beginning, communities of color, particularly Latino, Indigenous, and Black communities, were already vulnerable. As we've said, from medical deserts that exist around the United States to the role that those communities play as frontline workers, and because of a history of medical racism in the United States. These are the three things that we could have anticipated, and they reaped a significant toll on the Black community and on the Indigenous community. As we have noted across the country, these numbers are staggering. The last numbers I have seen, which are soon to be updated, suggest that 1 out of every 555 African Americans has now died from COVID-19 over the last 12 months when adjusted by age. When it comes to the early moment, what we saw were two specific failures. The first failure was the inability to translate to communities of color exactly what this pandemic and what coronavirus was. Cities, states, and the federal government stumbled around language barriers. They failed to engage organizations within communities of color early on to equip them and to educate them around the growing pandemic. And 3, unconscious bias in terms of racism placed people of color as a minor community in this story. We've seen this devastating toll. Soon after the quarantine, I lost neighbors who were Pacific Islanders, who worked in the medical communities, who didn't understand the impact of the coronavirus and how the coronavirus challenged the culture of their community, a community that was generational, that spent a lot of time together in family settings, and this left them vulnerable. That is one story of tens of thousands across this country. We have to understand, I think, one specific piece here. The failure in the early days was the failure to understand the role that inequality and racial bias always plays in the case of emergencies. And in this way, I want to situate the coronavirus and the pandemic and the quarantine alongside other natural disasters. Whether we are talking about Hurricane Katrina, whether we are talking about flooding in Florida, or whether we are talking about the deep freeze that hit Texas. At the end of the day, when disasters strike the United States, we should all anticipate that survivor racism follows. And survivor racism always places marginalized communities in a more vulnerable position because of existing discrimination, because of communities of color's fear with institutions that disadvantage them. And 3, because at the end of the day, network, privilege, and access matter in staying alive in the midst of a national disaster. And for many communities of color, they had access to none of those things. So the results are not shocking. What's shocking was the lack of government response. We understand some of that government response was lacking because of ideological position, but we should also understand that it was a huge government failure. I often hear government officials during that early period proclaiming to us, right, that they had warned the American public that a pandemic was coming. But here's the question that I ask in response. For those during that early period who were so confident that they had warned the American public, the question is why over those years they chose not to put anything into place. That is the role of government. And the story of the pandemic and racial inequality is a story, sadly, of government failure, one in which hundreds of thousands of people, disproportionately people of color, paid the price. Racism turned out to kill more people from coronavirus than the virus itself.
Thank you, Eric, for that illuminating. I learned something now. You called it survival racism. I have to keep that in focus and in sharp one too as we talk about this. Monique, I'm going to come to you next to actually comment, shed some light on the evolution of the pandemic in the carceral system. I bring that up because, as you know, one of the exposure risk factors is crowding. And that is the most crowded, the criminal justice system, the carceral, the prison complex, heavily crowded, and of course, predominantly Black and brown folks. What can you tell us about how the pandemic actually affected folks in the criminal justice system?
Absolutely. Thank you so much for that question and for this space to discuss this, which is often left out of our discussions of the inequities with respect to the impact of COVID. There was no question from the beginning that COVID would be devastating for incarcerated and detained people. That was not a surprise. And inaction early on to center decarceration efforts was quite honestly irresponsible and a complete failure of our systems. People in carceral facilities are exposed to extreme levels of overcrowding, but also highly unsanitary conditions and have limited access to healthcare. And the healthcare they do receive is very poor quality. On top of the fact that there's a high prevalence of chronic diseases, those diseases and conditions that we know lead to a high morbidity and mortality from COVID. And the US criminal punishment system is inherently going to disproportionately impact Black, Indigenous, and Latinx people because it was designed to do so. So by design, it's rooted in racist policies at every point of the legal system. So from encounters all the way to sentencing and parole. And with that said, because of that, the toll on populations of color is going to then follow. One of the first issues that was posed, the challenges, was the issue of data transparency. At the very start of the pandemic, the early reports were almost exclusively obtained through the lay media. And there was no standardization of reporting across carceral systems. And when I say carceral systems, I'm referring to prisons, jails, and detention facilities, which is a very wide umbrella. We have a very wide and generalized carceral system in this country. And because there was this lack of data transparency and continues to be a lack of data transparency, understanding the full scope of the impact on populations that are incarcerated, and also in particular, Black, Indigenous, Latinx populations, or other highly marginalized populations, such as the disabled, trans individuals, LGBTQ individuals, and we don't have a full scope of that because those data are not being shared. And in a very simple epidemiologic approach, in the sense that you don't always have what you need for the number in the numerator and the denominator to be able to estimate the burden and the incidence and the scope of the impact. What we do know is that the rate of COVID in US prisons is approximately 5 times higher than that of the general population. And based on data from Massachusetts, we know that is also true for jails. And jails are often left out of the conversation, but we have over 10 million people cycling through our jails every year. And we know from our data that it's approximately 3 times higher. And the mortality rate of those in US prisons is approximately 3 times higher. But these are all underestimates because of a lack of testing and poor reporting. I also mentioned briefly, we have not had a commitment to decarceration. And in the general population, as was mentioned, physical distancing is the most powerful public health tool we have. Physical distancing is not possible within carceral facilities. And what we know is that There were decreases early on in the population size in prisons and jails, but that was primarily due to a decrease in the influx of people in due to the closure of courts, and regular releases, but not concerted efforts to decarcerate. This can be done. This is a viable tool, and it has been done in some states, very recently in North Carolina due to litigation, but it has not been utilized. And thirdly, the role of community transmission. So community transmission due to incarceration impacts those communities that are disproportionately incarcerated, our Black, Indigenous, and Latinx communities, but also the communities in which staff live. And early work from correlational data from Cook County showed that a large proportion of the variability in cases of COVID in Chicago were associated with cases within Cook County Jail. But what has also been left out is the role that staff play in community transmission as well, both bringing disease in and also back into their communities, because carceral systems are an ecosystem.
Thank you so much. So I'm going to wrap up this phase with Giselle. Basically, same question, but let me preface it a little bit. It's clear from the work that the Institute of Medicine did, the study that was really published, the report in 2002, landmark that says unequal treatment, that pretty much concluded that racism is pervasive in the healthcare delivery system and could explain why we have racial disparities in health outcomes. The question to you then is this: can you comment on why government, medical, scientific community, everybody continued to focus on the higher rates of the comorbid conditions in communities of color, rather than thinking about the issues of racism in healthcare delivery? What are your thoughts?
Benga, thank you for that question. And I'm really honored to be on this panel with my colleagues. As you say, I'm already learning so much in this just few minutes. What I will say is that one of the key realities of being in the United States is focused on individualism and our consistent tendency to focus on individual behavior and in some ways actually blame the victim in health inequalities. And we saw this certainly in the early phases, and actually even now in the pandemic. In the early phases, it was a focus on what we can do as individuals rather than the systems that have conspired due to structural racism to increase the risk for any one individual, particularly in minority communities. What we've seen in the early part of the pandemic is that it's not solely about individual behavior. This is not solely about decreasing your risk by washing your hands and physical distancing, incredibly important and measures that we need to continue now. However, it's also about where you work, how you work, whether you can work from home, whether you're working shoulder to shoulder with someone in a meat processing plant, whether you even have employment at this point in time. It's about food insecurity. It's about access in your community to high quality healthcare. It's about the healthcare system creating a space that prefaces equity versus equality. In the early stages of the pandemic, we saw equality in terms of testing. All of us were scrambling to find ways to get tested to protect our loved ones and ourselves. However, the equity in rolling that out, being targeted based on what we know about inequalities in access, was absent. Right now, we're we're seeing that recapitulated in terms of the vaccine, and I know we'll get to the later parts later. But what we saw early on was sort of the Hunger Games of COVID testing. Where can you get a test? How long were the lines waiting for this? Again, it's the system that created these inequalities that where we've been focusing in terms of where we need to focus rather than focusing on individual risk. And it's these same systems that actually contribute and magnify the comorbidities that we see in communities of color. It's the places where people live and whether or not they have healthy food, whether or not they have a place to exercise safely and consistently, that leads to these higher rates of comorbidities that led to increased risk for morbidity and mortality, not increased risk for disease. The increased risk for disease is about the structural nature, the structural racism that constrains educational opportunities, constrains employment opportunities, has people working as essential workers, has people working in situations where they don't feel they can advocate for themselves to have the physical distancing. It's the systems that lead to the over-policing in communities of color, that lead to the cycling in and out, as Monique talked about, in our carceral systems and our punishment systems. I love that phrase, because that's really what it is. It's not about justice. These are the systems, and what the quote that we, so many of us that do this sort of systems work and are really talk about systems that are exquisitely created to create exactly the outcomes that we're seeing. And this is not only the tragedy of the early phase of the pandemic, but it's also the opportunity, which I'll know we'll get to talk about later.
I mean, this is great. I mean, for the audience, we're not losing time. What the panelists have done is actually really talked a little bit about the second phase, which, Giselle, I'm going to come back to you. You're going to lead us off on that second phase. So the idea of the second phase of the pandemic is between that period of June and November, or early December, if you may, where, a lot was happening. We knew that testing was important, as Giselle said, that, want to test our loved ones. It was clear already that, there's issues around structural racism as a driver, no longer about the individual, but as a driver of the disparate outcomes everybody was seeing. Operation Warp Speed was launched. And then an interesting term actually cropped up called the hesitancy. And that was coined to explain the low rates with which the communities of color were not getting tested. And I think Eric alluded to this. There was that issue of trust, and they weren't even engaged at the early phase. And so solutions to reduce crowding became key, and they were beginning to emerge in the carceral system. What was also abundantly clear was that the role of structural racism was explained in disturbingly higher rates. And then we had an awakening, if you remember, about the lockdown, and Black Lives Matter was beginning. We're hearing a lot, about the issue of social justice and the demonstrations across the country. So I think we learned a lot in that period. What I would like each of you to comment on, please, is the impacts across the carceral system, educational system, financial system, and the healthcare system. I know you've touched upon that, but Giselle, let me come back to you. As a leading scientist in the science of health equity and racial disparities in health, I know you've done remarkable work around the mechanisms of how these things occur in health outcomes. In your opinion, has anything really changed in what we're saying about the racial and ethnic disparities in COVID-19 outcomes?
Yeah, so I'll answer this in a couple parts. The first is, as you so rightly pointed out, and I think Eric as well, and even Monique, is that what we've seen in terms of health inequalities around COVID-19 are not at all surprising for any of us who do work in equity in any of the spaces that we work in. We know that, as one of our colleagues has said, if America gets a cold, Black and brown people get pneumonia. And so we know what we were going to see. We anticipated it at the very start of the pandemic. So is there anything new there? I would say what is new in this middle phase is this idea of being linked together, because in the past, health inequalities have been sort of over there. It's their problem, it's not my problem. It's their issue, it's not my issue. But what we've seen as Dr. Martin Luther King Jr. talks about is this inescapable network of mutuality that's tied together in the single garment of destiny, that whatever affects one directly affects all of us indirectly. This idea that inequality is not simply a Black and brown problem. It's a problem for all of us. And I think that realization, particularly with the murdering, the public murders of George Floyd, the continued injustice for Breonna Taylor, Ahmaud Avery, all of these people, the public murders that happened really sort of brought it full face for all of us in America. Some of us felt it personally, other of us felt it indirectly, all of us felt it vicariously, felt that pain. And so the inescapable linking of all of our destinies, I think, became evident in this second phase. And in fact, the data bore it out, right? Disparities started to close, not because Black and brown people were getting disease less, but because white America was actually getting it more. The misinformation, the highly politicized nature of this pandemic was starting to reach out into middle America, into rural communities, into white communities. And we were seeing this pandemic actually taking hold all across America and across all of our communities. And so that's the middle phase. It's that duality, the tragedy and the opportunity in that tragedy.
Eloquently said. Let me segue to you. I think what I'm hearing, just to quickly capture what Giselle just said, is that the intersectionality of how structural racism also affects other systems and other communities. So that's very important to appreciate that it's not a Black and brown issue. It's an issue of our entire system. And if we don't focus on it, it hurts everybody. By the middle phase, it has spread. Like we're hearing about meat packing plants, right, affected in rural America. So it's important. But so Monique, can you comment, at this time, there was some decarceration strategies being talked about. Can you comment on some of these strategies and how they may have inappropriately actually impacted, again, the Black and brown residents of the prison complex?
Sure. So one of the biggest problems is that we don't know. There's a lot that we don't know because there has not been a concerted effort to collect the data or to make the data available when it is. And this is another form of structural violence. So a lack of data is an attempt to make the problem invisible. And it's important to understand that, as was noted by Eric and Giselle, equity doesn't happen by accident. It happens through intentionality and decisions. And the decisions that have been made to not collect data or to not make data available allows for further inequities. For the places that have engaged in decarceration efforts, one of the concerns that we have is the centrality of those efforts on the types of sentences or charges, the types of convictions that people were sent to prison for example. And very often they have centered on the release of low-level drug offenders. And this is a place where, without intentionality, we can exacerbate inequities, because we know that Black, Indigenous, and Latinx individuals are more likely to be charged with harsher convictions and longer sentences. And so by centering decarceration efforts on the conviction, what we do is set up a system, a quote unquote race neutral policy that perpetuates racist policies that are baked into the system.
Very well said. That's what Giselle meant by saying equality is not equity. So we've got to be very, very surgical and really focus on the equity. So Eric, last word on this segment. The question would be, can you comment on how structural racism shaped the policies that were enacted to mitigate the impact of the pandemic across our economic, educational, and other systems during this middle phase?
So one of the ways that things began to mitigate themselves. So I'll talk a little bit about good news. So one of the mitigations was actually led not by a drive towards racial equality. It was actually driven by the desire for economic stability. And I think if elected officials had just been honest about that, it would have actually helped things. It would have prepared communities for the moment that they were in. But that wasn't the case. So what we saw at some point was increased testing for Latinos in the United States. But it had less to do, so we should just be clear, it had less to do with racial equity or seeking equity. It had to do with the critical role that Latino workers play in the functioning of the American economy. To be frank, without immigrants and Latino workers, the American economy would have tanked. This was often used to, I think, distort the actual equity numbers. But one thing that did begin to happen that I think we should point to is that we began to see medical personnel, particularly people of color, but also those committed to racial equity, to begin to raise an alarm around the disparity in terms of testing. And we began to see, at least in Oregon, some examples of priority testing lines being opened up in a way that allowed access to communities of color that were closer to transportation hubs. But this was very few and far between. At the end of the day, we have to remember that what occurred here was not a good news story for the most part. It is actually a tragic story of how communities of color paid the price during the middle phase of this moment. And I want to just quickly point to three things, and then we can get to them later. There are three things we need to pay attention to. The first is this, right? That many communities of color face the extra burden of poverty. Poverty means you don't get to sit in a line outside of a pharmacy for three hours, revving your engine, spending precious gas while you were in line for a test. Poverty means you utilize public transportation. Poverty means that you don't get to separate from your family when you think you might have tested positive. Racism means that you are not able to really segregate yourself from white society, who was more likely not to wear masks, right? People of color, because of the way race is structured in our society, are more likely to come into contact with white people than white people are likely to come in contact with folks of color. This left workers of color vulnerable, particularly in places like supermarkets and other places where people refuse to wear masks. The third is this: communities of color were also targeted by far-right conspiracies, disinformation, particularly via social media, that sought early on to create further mistrust within communities of color around the quality, right, and the availability of testing in significant ways. None of this was mitigated by government, and those communities on the ground, organizations that were most likely to be able to counter that, weren't empowered or resourced to be able to do so. And it will have an impact on the final vaccine era, as we'll get to in a second.
And now, Mitchell, let me segue to the last segment. And I thank you all for this riveting piece so far. So this is the vaccine phase, right? We have 2 vaccines, now 3, started in December when the FDA actually gave us the emergency use authorization for the vaccine. And interestingly, the data that began to emerge and the language that people used a lot was about vaccine hesitancy. This is also the time where, if you all remember very clearly, that we now have a good sense of some kind of treatment in place, and the public health community began to see all of a sudden that we see a sharp decline, right, with the advent of the vaccine in the number of deaths that were happening. But something else happened. If you look at the data for vaccination, to Giselle's point, if there was equality, there was no equity. We saw the same disproportionately lower rates of vaccinations in Black and Hispanic populations. And you begin to ask, what is going on? This is data from the CDC across about 40 states. Kaiser Family Foundation website will show that. And it's amazing that, again, even though they're more likely to suffer the bad outcomes of the COVID pandemic, they're less likely to get vaccinated. And the term vaccine hesitancy dominated the airwaves at that time. There was little focus on the issue of confidence and access. So here's my question to everyone. And one more thing that came out around that time was that data came out of the CDC that showed that, Black men, Hispanic men are about 3 years to 2.4 years not more likely. They lost about 3 years life expectancy, at least in the very first half of 2020. And most of it due to the COVID pandemic. So the question is this for all of you. Can you give me your take on the issue of vaccine hesitancy and then close out with some potential solutions that you see, just to give our listeners some hope on where we're headed? I'll give each person maybe about a minute and a half to make that happen. So I'm going to probably just go to Monique first.
Absolutely. I think that, so first acknowledging that only 15 states, including, for example, Massachusetts, included incarcerated people in phase 1 of the vaccine rollout. And that is a strong statement that Black, Indigenous, and Latinx lives are not valued. And so there is very rational concerns with taking the vaccine among incarcerated populations, not just due to the historical abuses of their bodies, but contemporary abuses. And one of the concerns that we have that is very closely tied with the solution is making sure that incarcerated people have access to trusted information from people that they trust, not from people that are in positions of power trust, but people that incarcerated people trust. And that means engaging with people with lived experience, bringing those voices to the table, dismantling the way that we think about access to those privileged spaces, and making sure that our community members with lived experience are at the table designing the solutions.
Thank you. So I'll go to Giselle next.
Thanks, Benga. So I prefer the term vaccine deliberation versus vaccine hesitancy. Vaccine hesitancy places the blame back on the individual for not doing a particular action. Deliberation is active. As Monique has said, they're looking around, they're looking at a healthcare system that has consistently and persistently demonstrated that their lives are valued less than others based on the poor outcomes that we have seen over and over again and done nothing about. And so I prefer that term. And just as Monique says, I think, the issue of vaccine distribution and inequities in distribution is also part of that deliberation. How are vaccines being distributed? Is it only an online platform, which it was early on? And we had vaccine tourism. We saw this in North Carolina, where Black and Brown communities would set up a vaccine site, and individuals from white communities and outlying higher SES communities would have the time just to be online because they're not working an hourly wage. They have a computer, they have high-speed broadband, and they would find those sites, traveling across county lines, traveling across state lines sometimes. And I've gotten those calls from my community partner in rural African-American communities where they were the one Black person in a crowded vaccine distribution site where people were coming from all over across the state for that. So that is, again, another example of equality versus equity, ensuring that we have targeted interventions on the ground to ensure that this work, to mitigate health inequalities. And the reality is testing is going to need to continue to happen, right? So we have all this focus on vaccines. Fortunately, the NIH has invested, billions of dollars in ensuring that we're getting the best test to market to more people more quickly. We need to make sure that our scientific and medical community is demonstrating that kind of trustworthiness in programs like the Rapid Acceleration of Diagnostics, or RADx. And we have folks on the ground, 69 communities across the country that are focused on Black and Brown communities and making sure underserved populations still have access to testing while we're laying, and many of them are laying on information, trusted information about vaccine, around vaccine confidence, I think was the term that you used, ensuring that people have accurate information from trusted sources, not only about testing, but also vaccines. And I think that's where the hope is. That's where when we're working and creating a system now that we can then leverage in the future. There will be another pandemic, as Eric mentioned, there'll be another community disaster. How do we ensure that the systems, the networks that are created now with community-based, faith-based organizations, health systems, and health departments that have finally come together to support Black and Brown communities, how do we ensure that those systems are institutionalized and remain in place to continue to address both acute illness and acute disaster and chronic disease?
Yes.
Thank you. That's a great point. And there are some questions I'm seeing here already. Eric, we'll give you the last word.
And I'll be quick. For anyone who may be watching a recording of this at a later date, if you are Black, if you're a Latino, if you're a Pacific Islander, right? If you are working poor, get a vaccine. I cannot underscore that we are still very early on in our understanding of coronavirus and COVID-19. There's much we still don't know about the variations, and you need to protect yourself and you need to protect your family and your friends. But we should be clear, in the attempt to achieve that, we are facing racial malpractice. It is a historic and present day system within the medical care system that begins at the pharma level and ends at the point where one is getting direct medical care. And that racialized malpractice sees people of color as less than. And that then exhibits itself in terms of how vaccines are developed to how they are distributed. So we have to, in this moment of crisis, we have to be diligent. And we have to understand that there are a number of barriers. We are dealing with a society of privilege. And that privilege has allowed people to create online scripts, right? That book appointments almost as soon as they are open, because these scripts repeat the web page. They just keep reloading these web pages. There are individuals with privilege and network who are actually hiring people, right? Paying people to book their appointments. This is what we are up against. When we go to get our vaccine, if you're a person of color, you may find yourself in an environment that does not represent you in terms of the racial makeup. But we need these vaccines because coronavirus is killing us. And the racial bias within our society is allowing that to happen. So here's what I say. At the end of the day, do not believe the disinformation that the vaccine is more dangerous than the coronavirus itself. Look around at the impact it has had on our communities, not just those who have died, but those who will walk around with long-term medical consequences from this virus. Don't think that taking the vaccine makes one weak. It does not make you weak. What it makes you is a leader in your community. This is about protecting ourselves right now. But the long term is this. We should not think that this virus has gone away. We don't understand the variations and mutations at this point. We still need to practice social distancing. And we need to now begin to hold the medical community in this country, from pharmaceuticals down to medical workers, in terms of building structures of equity. Why? Because we will see another pandemic again. And when that pandemic happens, it cannot play out in terms of our structures as it did over this last year. If it does, we may find communities of color devastated to a point that they cannot recover. And that would be tragic in the march towards civil rights and democracy in this country. We have to protect ourselves, and we have to address the institutional bias.
So Eric, I don't know why you're in this job that you do now. You should get a job in the public health arena.
Thank
you. I can preach about vaccine issues. But let me, Giselle, I want to comment on something. You kind of said it when we were prepping for this. And it goes to the point that Eric made, long-term strategy.
Yeah.
Can you just, in 20 seconds,
Sure,
the difference
absolutely.
between tactics and strategies
Yeah,
in confronting this issue?
So we have been very tactical in our healthcare system, our public health system, and frankly, our national initiatives have been very tactical, focused on short-term, focused activities rather than having a broad-term strategy. And this has to do not only with the testing, where it was very piecemeal and federated in terms of states and local governances standing up testing sites, but more so with the whole strategy. We knew the inequalities that we saw in testing would be recapitulated when it came to vaccines. There's nothing surprising about what we're seeing now, because it's the same system that we're using for testing, that we're the same way that we're thinking about vaccines. Again, very local, very focused, as opposed to a strategic initiative that really tried to mitigate the virus, learned from what happened in the testing arena, and created a system that already leveraged those local organizations, the community and faith-based organizations that came up and stepped up in terms of testing. We had to recreate that. We had no strategy. We had to recreate that for vaccines. Now, the reality is that, as Eric has said, there will be another pandemic. So how can we be strategic? How can we take what we've learned in this pandemic and create those systems, join the systems that are now touching each other, whereas before had been separate and apart? How can we join those systems together, create and strengthen the linkages between community-based organizations, faith-based organizations, our health system, and our public health system? How can we make sure that those that are touching are actually interdigitated? Because those are the systems that create health, right? These are the organizations that create health in our communities. That's how we're going to address diabetes, obesity, hypertension, is when we have those linkages in place. Food insecurity, housing insecurity, that are inextricably linked with our ability to stay healthy. That's the system that we need to create. And with this pandemic has showed us the power of that under incredible duress. And so how do we continue to connect those and make sure that we're prepared for the next disaster, the hurricane, pandemic, or mass shooting, unfortunately, that comes up? How do we ensure that we have that? Because the next tsunami, the mental health tsunami that's coming after this pandemic, we are woefully unprepared for.
Yeah, thank you. And then there's one more question I'm going to ask. I think we're run out of time, but it's only 1 minute I'm going to give for this one. I don't want to lose my job, because one of my great colleagues actually made sure that I put this question to you all. I'm going to read it. Structural racism has impacted Asian American communities, particularly those through immigration policies, lack of language access, and data inequities. One comment each. What do you all think about that?
This goes back to what Monique talked about in terms of our carceral system. One of the critical pieces that are missing is the data. It's really, it's structural racism that we can't even count the number of hate crimes against Asian Americans in this country because they're underreported or inaccurately recorded. So to me, there's a huge data piece for us to be able, and this is around, I think you mentioned data equity, making sure that every American is counted in the ways that, and we see this with Indigenous communities as well. The disparity doesn't exist if the data is not there. No one feels compelled to actually make a change if the data are not speaking. And so to me, that's the fundamental issue that we need to address.
Monique, Eric?
Yes, I would just say quickly, I think we have to understand the political violence and the hate crimes targeting Asian American communities is very real. I don't think we can ignore how some politicians attempted to use and did use coronavirus as an ideological position, right, in terms of their response to it, left Asian American Pacific Islander communities even more vulnerable to violence. But we should also remember the Pacific Islander community has been devastated by coronavirus in the United States. They have carried this price twofold in this country.
Yeah. Monique?
I would echo everything that Giselle and Eric stated, and then just round it out with recognizing that white supremacy feeds on keeping communities of color separated. It feeds on pitting communities of color against one another. And I think it's really inherently important that the recognition that white supremacy is actively benefiting from these types of divisions. And so that camaraderie and the concerted effort for all communities of color to support one another is central as an act to counter white supremacy.
So this is great. I'm going to round out by saying we've learned a lot. I want to thank all the panelists, and I'll bring Donna McKay back, Executive Director for PHR. But I want to just say one thing here. There is hope, and we need to focus on that hope. And the strategies long-term do matter. We cannot keep our eyes off that ball. The intersectionality of all the different systems is key if we're going to be addressing the issue of structural inequities and how they impact our health. Thank you all for joining us. And Donna, please, back to you.
Thank you so much. Thank you for taking us through this discussion. I really value the lens of analyzing these three stages as you position this conversation in your very targeted questions, which allowed us to gain so many insights from our incredible panelists on the role that structural racism has played in each phase of this response. And we can see future phases through this discussion, and really how the failures, which are so important to discuss and dissect at each phase, led us to this point today of over 545,000 deaths, so really just a staggering number. And I really appreciate that our panelists took us to the future and really sending these such important messages for all of us that, as Giselle said, ensuring that the systems and the networks that are coming together now are institutionalized and remain in place and expand. Building structures of equity, Eric, I think is the phrase that you used. So it's such an important and valuable conversation, and PHR will post this webinar recording of this on our website and on our social media platforms. And so I ask those who are listening to please consider sharing this with your networks, and in particular, people who are in positions to influence these systems that we were discussing today. And lastly, please join us for future webinars as we continue these discussions and try so hard to learn as we think about future responses. What is very obvious in today's conversation as well is the important role that medical personnel can play for good. Eric, I agree, you should become a public health expert, but the advocacy that you all are doing is so critical. So thank you so very much for today's just wonderful conversation.
Thank you.
Thank you.